Thank you very much, Tony. If you'd like to stay there, and if the two other speakers would go and join Tony at the podium, and could you put up my slides again and go back to the panel discussion. We've got a panel discussion now, but obviously there may be some questions related to the talks that we've just heard. So if there are either questions related to our panel discussion or questions to the talk, please come up to use the microphones on the side. The panel discussion is about how can radiation dose be reduced during treatment. Could somebody put forward that next slide for me? I've just put up a few things, and Tony's already addressed this. First of all, we're talking about hemorrhage. This is life-threatening hemorrhage, and perhaps when worrying about the radiation dose during a treatment that is trying to save somebody's life or womb is perhaps not uppermost on our minds, but we're talking about a young group of women, and we expect them to survive, and they're going to go on, and the very bit that we're irradiating is right by their ovaries. So I think it is something we do have to consider. I've put up there a few things which I think are important when it comes to trying to reduce radiation dose. Olivier, which of these do you utilise? Do you think these are all important? Are there issues about some of these things that you think it's just not practical?
I think it is maybe a combination of on the 5 lithium. I think it is reducing the pulse fluoroscopy. It is very, very efficient.
Yes.
If you decrease the number of pulse, you maybe just increase the intensity of the pulse, but you reduce the number of the pulse. You have still a very good image, very informative, but with a very low radiation dose. After I like the modern angio suite. If you use flat panel, you increase the quality of the image.
There's no doubt that modern angiographic equipment, every time we get a better machine, the doses are less, our images
are better. It works together.
Absolutely. So I think the pulse fluoroscopy and modern suite, we really do minimise the dose. What do you feel about coning? Because I'm a little bit reticent about coning. I like to see where my embolics are going, and sometimes coning in too much doesn't give you the full picture, so it's a little bit of a tension there. I just would like to make sure that I have no backflow or no non-target embolization. So personally, I use I start the injection for postpartum hemorrhage, especially because the problem is maybe quite different for cancer or other application. But for postpartum embolization, I start the embolization without or just one push every 8 seconds or something like that. That's a very good point, because when you're starting your embolization...
I start embolization without scopic control.
Yes. You know, we're always taught to screen, to see exactly what we're doing, but really at the beginning of your embolization, you can sometimes do the first bits blind, which goes against our instinct. Tony, is there anything else you would add as an important aspect or something we've missed off there?
Maybe, I mean, all these are or should be generally used things. I mean, cone, use the pulse fluoroscopy and so on. But I would stress maybe the modern angio suites. I mean, now we are facing the revolution on imaging, and at least in my center, we have new equipment which is reducing the radiation dose by 70%. So I think that's, I mean, this technology will change our practice, since we can do longer runs maybe, but definitely what we achieved most is to use only fluoroscopy for recording the runs. Don't use DSA.
You don't need angiograms. They produce nice pictures, but they're not necessary. I'd like to hear from Professor Gupta as a clinician. Do you think about radiation at all when you send women for these things?
Never.
And are we too obsessed?
Never, ever think about radiation.
Okay. And what about...
It's just that it's one of those things that it's not in our field, and we just don't worry about it. I mean, the only time we know that we use the radiation is because of pregnancy in general, but other than that, we don't really think about it.
I mean, you talked about the prophylaxis, and we put in prophylactic occlusion balloons. prior to caesarean section in women that we think have got placenta percreta. Now, of course, then we're irradiating that. It's not a fetus, it's a baby, isn't it, really? It's just about to be delivered. Any thoughts about that? The only thing that we worry about is not the radiation dose, it's about how long we need the time from the occlusion of the arteries to the delivery, because that is yes, you
causing
said that. I was very interested when you said
That's
that,
the
because
hypoxic
we
event.
don't inflate the balloons until the baby's delivered.
Yes,
so we
but
don't think about that. Do you inflate the balloons first?
Well, no, I'm just, that's the only thing that goes to my mind, is
Okay.
that have they inflated the balloons or not?
Yeah,
and so we just need to crack on with
Okay.
it. So
So maybe we're a bit obsessed.
Yeah.
We have a question.
May I have a comment? In life-threatening situations, you don't think about the radiation. That's absolutely right. In case of embolization, it's essential to have an oblique view to navigate your catheter or microcatheter to the place where you want to embolize. But once you get there, I think it's essential to turn the machine to AP view,
Yes.
and then this reduces, even fluoroscopy, you will reduce the dose a lot.
Yes.
So you don't have the oblique with more radiation, but the AP.
Yes, absolutely. That's a very good point. And I would think probably everybody does do that, do they? Because you oblique to get access to see the origin, and then you go AP again. Yes, excellent point. Yes,
The
please.
question I have for Dr. Gupta and Dr. Pellern, you have labor and delivery and IR in two different sites. Do you really get the patient within that golden hour, or what is the time span you get the patient transferred to your...
we don't get it. We're bad in that sense. So this is where we've got a very good interventional radiology team. There's, I think there's about, I lose count because every time you look at the thing, they've got another radiologist who's on as part. So there's about 9 of them, but they do everything from cranial to everything. So we are sort of just a small part, but I think we can involve them much better. But remember, we've got that 40-yard road in the middle, and even then it sort of delays things. So the hesitancy we have, oh my God, we've got to transfer the patient. Can we try and do it as much as possible? But I think we will end up using a lot more if we had a on-site, we're thinking of putting a link, like a bridge or something.
This is something we have special because my institution is not a maternity hospital. So meaning that we are a very big hospital, we are doing a lot of cases of interventional radiology, and around us we have a lot of very small hospitals that have private practice, and they have their maternity, or they are only maternity. And so they ask us to get involved in a very big, it's like a big circle of protection. So that's the reason why we designed the golden hour, just to stay inside. Because we know that if we get outside the golden hour, it's becoming more and more difficult for us. So that's, and the last thing, because we're working in Paris, that's a very big city with huge problem of traffic. So if you would like to be reachable in less than 1 hour, you have just to organize everything. That's the reason why we designed like it. And finally, it works finally well.
Yeah. We have lots of questions, so can we move on to the next question? Hello.
Gunnar Sandbeck, Oslo, Norway. I'd like to, we are discussing postpartum hemorrhage, and there is one technique that none of you have alluded to. We always, as experienced interventional radiologists, we don't need fluoroscopy always. There is the possibility of placing a 8 French sheath and through this an occlusion catheter in the distal aorta. Mm-hmm. And in this way, we're able to control bleeding and wait for the tonus in the uterus to come back. Do you have any comments?
So this is occluding the aorta just as a therapy itself, not just to manage the immediate hemorrhage and transfer a patient?
Well, actually, it is both.
Well, yes, but you've used it just as the therapy per se.
It is a sort of a bridge to either for nature to sort of solve the whole problem, it can save the uterus, because it gives the gynecologist sort of, he's then brave enough to sort of be a bit
Has
more.
anyone used that just as a therapy by itself?
No, well, I'm interested. I mean, it's the only worry that I would have is when you've deflated your balloon, or whatever you've done to occlude the aorta, which is a large, obviously, bilateral legs, and so, am I going to get bleeding afterwards? That goes unrecognized. So I don't know. That's the only concern.
Mm-hmm. I mean, certainly people use it in the common iliacs, and it certainly can be used in the aorta. I've always used it as a sort of tamponade to get the patient safely to somewhere else, and perhaps you'd want to deflate and keep the catheters in so that if there was any rebleeding, you could stop the bleeding again. That's fascinating, and I think we'd like to see your results.
The good thing about this is that you can inflate the balloon and let it stay for some minutes, and then deflate it. And if it starts bleeding, then you have to inflate the balloon again.
Okay.
It's quite simple. We have a nice little kit that we run into the gynecology department with.
I think you should write that up.
Actually, we have.
You have?
Actually, I wrote an
fantastic.
article about that, and it was published in the Acta Anesthesiologica in
which journal?
Acta Anesthesiologica.
Ah, but we don't read Acta
And
Anesthesiologica.
it's from
Why
January,
isn't it in a
2012,
radiology
and it's published.
Yeah.
And you were a bit considered what happens when you deflate a balloon. Well, sometimes it starts to bleed again, and then you inflate. So primarily, you have the balloon inflated for about 10 minutes, then you deflate, a minute or two. You get either you have control in the bleeding field in case it's a cesarean, and you see where it bleeds, and you can suture, and then you can blow the balloon up again, and so you can go on like this for about 30-40 minutes, and then very often you have control, and if you don't have control, then we bridge it over to the department, where we can put it in the angio suit. Yes.
Very good, but please publish that in radiology next time.
Well, okay, yeah, well...
I missed that one.
So it's very well described.
Very good, very good. That's very interesting. Thank you very much for that very interesting comment. We have another question, and I think we have to close the session. I'm very pleased there are so many questions. Thank you.
Thank you. It's Dr. Johnson from Oxford. This is actually a question about diagnostic radiology rather than interventional radiology. What sequences do radiologists use here in the audience, or yourselves, for identifying the patients, pre-delivery? Those that do have the sort of placenta accretias, those that have perhaps had hemorrhage in the past. Because where I work in a tertiary centre, patients arrive at sort of 38 weeks. I get a phone call from the gynaecologist or the obstetrician saying, oh, we're going to deliver them tomorrow. We know there's been a history of XYZ in the past. Can you do an MR scan? And, I would love to know what sequences people find most useful. I want to be able to better aid my...
That's very interesting, because in our hospital it's ultrasound that makes the diagnosis, and we very rarely do MR. But what do our panel say? I'm not a diagnostic radiologist anymore, so I can't answer that. Tony, Olivier.
I'm not a diagnostic radiologist, but I mean, if you speak about the abnormal placentation, and how to reveal that. I mean, this is crucial, and usually it's the diagnosis established by ultrasonography. So, and we have also the protocol how to set up the delivery if there is abnormal placentation. So, I mean, we use these balloons or being ready for severe hemorrhage. So, but I mean, ultrasonography should be enough.
It's very accurate.
We do ultrasonography as well. But sometimes in ultrasonography, if there's a equivocal finding, then they come to us for MR. And I wondered if anyone had like a favourite sequence or a top tip.
I think you'd have to look at the American. Maybe we've got an answer here. I mean, the American journals the Americans use MR.
Yes.
The Europeans use ultrasound. It seems to be.
Yeah, you're right.
Yeah.
Hello, my name is Kirsi Härmä from Finland. Well, I have proceeded about 35 fetal MRI. Also, placentation abnormalities, and I prefer very fast sequences due to haste. And you also can do diffusion-weighted imaging with the p-values 0 and 1,000. And I work together with our perinatologist, Dr. Orden, and she's doing the ultrasound I go with because I'm also a gynecologist, and we proceed also MRI. And you can see the white placenta with new vascularization, perhaps infectation, and you have to check out the myometrial outer and inner layer. It's a little bit difficult, I have to say.
I think we will leave you two to discuss diagnostic MR because we're over time now. Thank you very much for a very interesting and interactive session. Thank you.